Greetings from Spain. Thank you very much for watching this presentation exploring the relationship between urinary culture results and the choice of the prophylaxis protocol against recurring urinary tract infections in women. I have no affiliation to disclose regarding this presentation. In recent years, it has been described that the urinary tract of women with a recurrent urinary tract infection is not sterile. In addition, there are differences in the diagnosis meaning of certain bacteria, so the microbiome could assume an interference in the choice of the most appropriate prophylactic treatment. The objective of the present study was to know the characteristics of the urinary microbiome in women who use different measures to prophylaxis to prevent recurrent urinary tract infections. A prospective multicenter study was developed, including 1,614 adult women who received prophylaxis against recurrent urinary tract infections within 1 year. These patients were divided in 3 groups according to the prophylactic treatment followed. In Group A, patients were given antibiotic prophylaxis in conventional suppressive regimen. Patients in Group B were treated with a polyvalent bacterial vaccine, and a patient in Group C followed other adjuvant measures. In all patients, age, secondary diagnosis or concomitant diseases, concomitant treatments and urine cultures for fungi and bacteria were recorded. Mean age was 57 years, with a range between 18 and 93 years. The mean age was statistically lower in Group B. The most frequent comorbidity condition in all groups were arterial hypertension. Patients in Group B had a higher proportion of patients with the main secondary or concomitant disease, such as diabetic mellitus, depression, hyper and hypothyroidism, and musculoskeletal disorder. Before treatment, average time suffering from recurrent urinary tract infection was 5 years in the general sample, and this time was significantly lower in Group B. If we focus on the number of UTIs after the initiation of treatment, patients had on average 4 and 5 episodes at 3 and 12 months respectively. Both figures were significantly lower in Group B. In total, 1,572 positive urine cultures were found. The most frequent bacteria was Escherichia coli, followed Enterococcus and Klebsiella. There were significantly more urine cultures with E. coli in Group B than in Group A and C. Similarly, Enterococcus fecalis was more frequently in Group B than in Group A. Candida glabrata was only found in 6 patients in Group C. Morganella morgani, Streptomonas maltophilia, and human papillomavirus were identified only in 3 urine cultures each of patients in Group A. Patients' general health status may influence the choice of the prophylactic treatment against recurrent urinary tract infection, since patients in the group receiving antibiotic prophylaxis have more comorbidities. However, it has been already shown the efficacy of Uromune in elderly patients in both genders. Also, the microorganisms causing recurrent urinary tract infection is important in selection of the prophylactic regimen proposed to the patient. It is noted that the mannose binds to the type 1 pili and saturates the adhesive film H and therefore prevents bacterial adhesion to the urothelium. Although research of type 1 pili focuses mainly on E. coli, it has been identified in other enterobacteria such as Klebsiella, Shigella, Salmonella, Serratia, and Enterococcus. This means that approximately 20% of patients in the sample would not benefit of this treatment. MB140 favors immunoactive prophylaxis using a suspension of inactivated complete cells of different strains, bacterial strains of Escherichia coli, Klebsiella pneumoniae, Proteus mirabilis, and Enterococcus fecalis, covering a wide range of pathogen-associated molecular patterns, even of other microorganisms not included in the formula. In conclusion, we have seen that there are differences in the distribution of the urinary microbiome of the women with recurrent urinary tract infection. This fact may have clinical consequences at the time of indicating a prophylactic protocol. The polybacterial vaccine is indicated in broad spectrum profiles different from isolated Escherichia coli, with a significant reduction in the number of UTI episodes. Thank you very much for your attention.